I'm Ping Hin from Unity of Malay Medical Center. My topic is patient factors affecting transit time flow measurement for LIMA LAD and association between pulsatility index and postoperative outcome for CABG. I have no conflict of interest with regards to this presentation. Perioperative MI ranges from 3 to 10% in CABG. Publishers et al. Reported that 1% who underwent CABG had severely compromised hemodynamics due to postoperative MI, and 21% had incorrect anastomosis. Intraoperative graft assessment by TTFM was shown to improve postoperative outcomes by detecting intraoperative graft failure. TTFM is recommended by the European Society of Cardiology for intraoperative graft assessment. Tucker et al. Recommended a PI of less than 5 as a cutoff. Giammaco et al. Reported that PI more than 3 or mean flow value of less than 15 mL per minute were independent predictors of graft failure. There's little literature on the association of preoperative factors with TTFM, and the views on the correlation between TTFM and postoperative outcomes are conflicting. Thus, we aim to identify patient factors affecting TTFM for LIMA LAD and association between PI and postoperative outcome for CABG, both for arterial and venous grafts. This is a retrospective study conducted at UMMC. All patients who had isolated CABG from January 2017 to September 2020 were recruited. There were 155 patients in total, all operated by a single consultant. Data on patient characteristics included age, gender, comorbids, functional status, and LV ejection fraction. LV dysfunction is EF, less than 40% within 3 months before surgery. Recent MI is documented MI within 1 month before surgery. Advanced CKD is CKD stage 4 and higher. Operative data included duration of cardiopulmonary bypass and aortic cross-clamp and TTFM. TTFM is measured using Medistim Varicule system. Post-operative outcome included the need for chest reopen, low cardiac output syndrome, perioperative MI, atrial fibrillation, stroke, renal failure, prolonged ventilation, surgical site infection, and mortality. Low cardiac output syndrome is post-operative cardiac index less than 2 liters per minute per meter square, accompanied by signs of poor peripheral perfusion, oliguria, and metabolic acidosis. Post-operative renal failure is renal dysfunction requiring post-operative renal replacement for patients who did not require renal replacement preoperatively. Prolonged ventilation is defined as patients requiring invasive ventilation for more than 5 days. The mean age of our patient is 58. Our patients are predominantly males, and a significant proportion had recent MI and diabetes mellitus. More than half of our patients were symptomatic prior to surgery. The majority had LIMA LAD with PI of less than 5 and arterial grafts with PI less than 3. Slightly more than half had PI less than 3 for the venous grafts. This table shows that only advanced CKD is significantly associated with PI more than 5 for LIMA LAD. eGFR less than 30 increases the odds by 18 times. This table shows that for arterial grafts, if PI is less than 3, patients are less likely to require IVP and less likely to require prolonged ventilation. This table shows that there is no significant difference in terms of post-operative outcome between venous grafts with PI less than 3 and PI more than 3. Many studies suggest that TTFM predicts graft failure. Meta-analysis conducted by Twist et al., which included 8,000 CABG cases, showed that 4% required revisions based on TTFM. Jokinen et al. Reported that TTFM predicts graft failure within 6 months, and PI is the best predictor of early graft patency. Lee et al. Found that BMI and systolic blood pressure affect TTFM, particularly mean flow rate of LIMA LAD. Our study showed that patients with advanced CKD have a significantly higher odds of having a PI of more than 5 for LIMA LAD. However, the views on the correlation between TTFM and postoperative outcomes are conflicting. Kaiser et al. Reported that 7% with PI less than 5 and 17% with PI more than 5 had major adverse cardiac events. Mortality rates were significantly lower for grafts with PI less than 5 compared with those with PI more than 5. In contrast, De Leon et al. Suggested that TTFM of functioning grafts do not predict long-term survival or performance of new PCIs. Our study showed that patients with arterial grafts with PI less than 3 are less likely to require IBP or prolonged ventilation. There's no significant differences in postoperative outcomes in venous grafts based on PI. The reason behind, we believe that it is because most arterial grafts are connected to the left anterior descending artery and left circumflex artery, whereas most venous grafts are connected to the left circumflex artery and the right coronary system. Thus, a suboptimal PI for arterial grafts leads to worse outcomes, whereas a suboptimal PI for venous grafts does not affect the outcome as much. The limitation of this study is that it is a single study, thus future study would require the expansion of the patient inclusion. These are my references. Thank you.